Assalamualaikum and hi. This is my video presentation for assessment of radiographic image evaluation, code MRD 444. My name is Nurul Ain binti Muhammad Samsudin, student number 2024882748 from group NHSI 4B. The content of my presentation consists of radiographic anatomy, positioning criteria, exposure criteria, and radiographic image evaluation of PA hand X-ray using placement method. Placement method is used as image evaluation criteria for optimum image quality or related projection. We use this method to evaluate whether the image or radiograph produced is acceptable or should be rejected. The criteria of the placement method includes first the P for projection, which is the first important criteria to help us to determine whether the image produced can be used for diagnosis. Second criteria is alignment, which used to determine the alignment between the X-ray tube, patient, and IR. Third criteria is the collimation, which used to evaluate all the required structure are included in the collimation field. Fourth criteria is the exposure factor. This is also important criteria because only optimum exposure can demonstrate better image for diagnosis. In this placement method, we learn to evaluate the contrast and density used by looking at the thin and thick structure as the guideline. Fifth criteria is marker, which used to evaluate the evidence of the marker. Sixth is aesthetic, used to evaluate the correct film size or any evidence of artifact. The last criteria is we need to evaluate the evidence of name, patient's name, and identification, which is also important in any examination. After we have reviewed all the criteria, only then we can decide whether to accept the image or if a repeat exposure is necessary. Firstly, I will introduce the radiographic anatomy of the PA hand. The image on the left side shows the bony anatomy of the hand, and on the right side is the PA hand radiograph, allowing us to compare the anatomical landmarks with their appearance on X-ray. In this radiograph, we can see the carpals, metacarpals, and the phalanges. The phalanges are organized by digit starting from the thumb as the first digit, followed by second, third, fourth, and fifth, corresponding to the index through the little finger. Each digit, except the thumb, has three phalanges, which are proximal phalanx, middle phalanx, and the distal phalanx, while the thumb has only proximal and distal phalanx. This view also demonstrates the joint, including the interphalangeal joint on the proximal and distal, the metacarpophalangeal joint at the base of each digit, and the carpo-metacarpal joint, which connecting the metacarpal to the carpal bone. The metacarpal has three parts: the base, shaft, and head. This projection should also include about 2.5 centimeters of distal radius ulna at the inferior part of the radiograph. Now I will explain the positioning criteria for a proper PA hand radiograph. First, there should be no soft tissue overlap between adjacent digits, and the distance between the metacarpal heads should appear equal. This indicates that the hand was positioned flat and evenly on the image receptor. Second, the concavity of the midshaft of the phalanges and metacarpals should specifically from the second to the fifth digits appear symmetrical on both sides. This helps to confirm that there's no rotation of the hand. Next, the joint should be clearly visible and open. This includes the interphalangeal joint, metacarpophalangeal joint, and the carpometacarpal joints. The joint open spaces indicates proper positioning without overlapping of the bone. For the thumb, it should be visualized in a 45-degree oblique position, which is the standard for proper evaluation in a PA hand image. And the phalanges and metacarpals should be demonstrated without foreshortening. If they appear foreshortened, it suggests that the hand was flexed or not fully in contact with the receptor. Meeting all these criteria ensures a diagnostic quality image that allows accurate assessment of bony anatomy and joint spaces. This is an example of incorrect positioning, which evidenced by the distance between the metacarpal heads, which are not equal in distance. The distance between the 5th and 4th metacarpal heads are closer than the distance between the 2nd and 3rd metacarpal heads. Second evidence is demonstrated by unequal mid-shaft concavity of the proximal 2nd, 3rd, and 4th phalanges, which indicates external rotation. The 2nd and 3rd metacarpophalangeal joint are also closed, which indicates the hand is flexed. To improve this positioning, we can internally rotate and fully extend the patient's hand and fingers until the palm and fingers are flat against the IR. The second example of incorrect positioning shows the 2nd, 3rd, and 4th proximal interphalangeal joint are seen close, indicating the fingers are flexed. The image also shows the over-collimation on the inferior side, which is supposed to include approximately 1 inch or 2.5 cm of distal radius ulna. The position can be improved by fully extend the patient's fingers until the palm and fingers are flat against the IR. Then, open the longitudinally collimation to include the inferior part, about 1 inch of distal radius ulna. To determine whether the exposure factors used are sufficient, we can use both thin and thick anatomical structures in the image as the guideline. To evaluate the contrast, we assess the visibility of the bony cortical outlines. For thin structure, we look at the distal phalanges, and for thick structure, we can look at carpal bones and the distal radius ulna. For density, we can look at the bony trabecular pattern. Bony trabecular pattern should be seen in thin structure like the distal phalanx and the thick structure like the carpals and distal radius ulna. This is an example of incorrect exposure. Contrast for this radiograph, the thin structure, which is the bony cortical outline of the distal phalanx, are clearly seen, but the thicker structures, such as the bony cortical outline of the carpal bones, are not well visualized. This suggests that the exposure is inadequate and resulting poor contrast. For the density, it shows that the thin structure, which is the bony trabecular pattern of the distal phalanx, can be seen, and the thick structure, which is the bony trabecular pattern of the distal radius and carpal bones, are also seen. This suggests that the density of the radiograph is optimum. To improve the contrast, we need to increase the KVP 15%, and to maintain the original density, we need to decrease the MAS 50% due to the increasing of KVP will affect the opacity, Second image for incorrect exposure shows the contrast is optimum by looking at the thin structure, which is the bony cortical outline of distal phalanges, can be seen, and the thick structure, which is the bony cortical outline of distal radial head and carpal bones, are also can be seen. For density, the thin structure, which is the bony trabecular pattern of distal phalanges, are fairly seen, indicates that it is overexposed. And the thick structure, which is the bony trabecular pattern of distal radial head and carpal bones, can be seen. So to improve this exposure, we should maintain the KVP and decrease the MAS by 50%. Now, we move to the radiographic image evaluation of a PA hand radiograph using Paceman method. We start the image evaluation of the PA hand radiograph with the first criteria for evaluation, which is the P for projection and position. The image shows a projection of PA hand. I say so because it shows the phalanges and metacarpals are demonstrated without superimposing each other. The distal phalanges demonstrate at the superior part of the radiograph, and the distal radius demonstrate with slight superimposed by the ulna on the inferior part of the radiograph. For position criteria, the thumb is seen in 45 degrees oblique. The interphalangeal joint, metacarpophalangeal joint, and carpometacarpal joint are demonstrate open. But the distance between the metacarpal heads are not equal, and the midshaft concavity is also unequal on the second and third phalanges and metacarpals. This indicates that the image is slightly external rotated. To improve the rotation, we should internally rotate and fully extend the patient's hand and fingers until the palm and fingers are flat against the IR. Second criteria for Paceman method is the alignment. We evaluate the alignment through three categories of alignment, which are from X-ray tube to IR, X-ray tube to patient, and patient to IR. For the first category alignment, from X-ray tube to IR for this image is incorrect because the distance between the collimation border to the edge of film is unequal between the superior and inferior side. The distance on the superior side is less than the inferior side. Second category of alignment is between the X-ray tube to the patient. We evaluate the alignment by evaluating the distance between the central structure, which is the third metacarpophalangeal joint, to the edge of collimation border. For this image, the alignment is incorrect because the distance between the central structure to the edge of collimation is unequal. The distance on the inferior side is more than the distance on the superior side. The last category of alignment is between patient to the IR. We evaluate the distance between the central structure to the edge of film. For this image, the alignment is incorrect because the distance between the central structure to the edge of film is unequal. The distance between the central structure to the inferior border of the film is larger than the distance between the central structure to the edge of superior border of the film. The centering point for this radiograph is incorrect. The standard centering point for this image should be at the third metacarpophalangeal joint. Third criteria of the Paceman method is the collimation. Collimation should be done to all four borders and includes on the superior side, includes the distal phalanges, on the inferior side should include about 2.5 centimeters or 1 inch of distal radius and ulna. On lateral side should include about 1.25 centimeters or 0.5 inch of the first and fifth digits skin margin. There is also no evidence of radiation protection apparatus seen in the radiograph. Next criteria is the exposure factor. We evaluate the contrast and density of the image by looking at the bony cortical outline of the thin and thick structure. The thin structure for this radiograph is the bony cortical outline of the distal phalanges, which are visible, and also the thick structure, the bony cortical outline of the distal radial head and carpal bones are also visible. This indicates that the KVP used for this projection is adequate to demonstrate the structure. To evaluate the density, we can look at the bony trabecular pattern of the thin and thick structure. For thin structure, we can look at the bony trabecular pattern of the distal phalanges, which are visible. And the thick structure, we can look at the bony trabecular pattern of distal radial head and carpal bones, which are also visible. This indicates that the MAS used for this projection are also sufficient to demonstrate the structure. Next criteria is anatomical marker. There is evidence of an anatomical marker shown in the radiograph correctly placed on the left superior side of the radiograph and placed appropriately without superimposing any region of interest. Next criteria is aesthetic. The film size used is correct, which is the size of 24 times 30 centimeters, which is sufficient to demonstrate all the structures of interest. There is no evidence of artifact on the radiograph. Now we come to the last criteria for the placement method, which is the name and patient's identification. The patient's name and ID, date of examination, and place of examination are not visualized on this radiograph. The name and identification information should be clearly visualized on the radiograph at the appropriate area without superimposing with structure of interest. As the final evaluation for this radiograph by placement method, it shows that the positioning has a slight rotation which are tolerable. The alignment is acceptable even there is slight misalignment which do not result in cut-off region of interest. Anatomical marker is present and correctly placed. There is also no evidence of artifact and it has no patient's name and ID. As the conclusion, this radiograph is unacceptable and should be rejected because it has no patient's identification and information. That's all for my presentation. Thank you for your time.